evening, everyone. I'd like to welcome everyone to tonight's MSIG webinar, where we're continuing the series on textbook injuries, where each speaker will share their expertise on a specific sport and identify the most common injury or injuries from the sport. It's an honor to have the following AMSSM members serving on our 4-member speaker panel. Dr. Robert Bowers will give a presentation on baseball. Dr. Aaron Lear will give a presentation on softball. Dr. David Olson will give a presentation on football, and Dr. Ashley Austin will give a presentation on basketball. My name is Kylie Yamauchi, and I was an MSIG officer for the past 2 years, and I will be serving as the moderator for tonight's webinar. I'm currently a second-year medical student at the University of Hawaii School of Medicine. And after all of our speakers have shared their presentations, I will be the moderator for the Q&A session. So during the webinar, if you have any questions, please feel free to put them in the chat and I will read them during the Q&A segment. Now it's my pleasure to introduce Dr. Robert L. Bowers, who will make a presentation on baseball. Dr. Robert Bowers is a sports medicine physician at Emory in Atlanta, Georgia. Prior to medicine, Dr. Bowers played Division I college baseball at Furman University and received a PhD in exercise physiology from Auburn University. He subsequently attended medical school at Philadelphia College of Osteopathic Medicine, Georgia campus, and completed a residency in physical medicine and rehabilitation and sports medicine fellowship at Emory. His current clinical and research interests include baseball medicine and throwing athletes, advanced interventional ultrasound guided procedures, diagnostic ultrasound, and evidence-based use of orthobiologics. Specifically, Dr. Bowers is interested in neurogenic thoracic outlet syndrome and peripheral nerve conditions in throwing athletes, as well as platelet-poor plasma injections for the treatment of muscle injuries. Dr. Bowers is the director of the Emory Baseball Medicine Program and serves as team physician for Georgia Tech Baseball and the Atlanta Braves. Dr. Bowers, you may begin your presentation now.
All right, so we'll get started. Thanks for the intro. Okay, so thanks everyone for coming for this tonight. I'll take 10 minutes to go through textbook injuries for baseball. If I get distracted at all, I'm watching my son, he's playing PlayStation behind me. So if for some reason I get distracted, that's why. But I appreciate everyone for having me. So we'll talk about baseball. First, baseball medicine is kind of my my primary, I guess, passion within sports medicine right now. We have a baseball medicine program at Emory, and I help take care of Georgia Tech baseball and the Atlanta Braves. Also do some basketball, College Park Skyhawks, but baseball is the primary sport that I'm taking care of and practice on a day-to-day basis. So I have no disclosure. So how did I get involved with baseball medicine? So I played, I was a very average college baseball player at Furman University, which is a small Division I school in South Carolina. So small school, but cool during college. We got to play all the big schools, played South Carolina and then Clemson and Georgia and a lot of the other big schools around the Southeast, and a lot of big schools from up north that actually come down and actually play us at our stadium that you see right here, like Penn State and Michigan State would come down and play us at home early in the season while it was still winter up north. This is on the right, this is the last picture of me ever in a baseball uniform. And it was after our last game, Southern Conference tournament in 2006. And there's a picture of my dad took me, and it was just after the game. And you realize that it was over. And I just kind of took a knee, by the line and just kind of looked out on the field and, didn't know anyone was taking a picture of me. And you just look out at the field and wonder, this game that you kind of poured your life into, that it's all over. Like I said, I was a very average college baseball player and was not going to play professionally. And so you wonder, you still love this game and how, how are you going to remain involved with it? And you just can't see what the future is going to unfold or how it's going to unfold or how you're going to be able to remain involved. You just know you want to. And then, you fast forward to 2021 and I'm taking care of the Braves and I'm in Houston and we win the World Series. And, if you had talked to the 12-year-old me growing up in Atlanta that I would be on the field with the Braves winning a World Series. And then after that, be in the locker room with the World Series trophy and goggles, spraying champagne. I never would have guessed it. This is my first year working with a professional sports team. Probably I was 3 years out of fellowship at this point. So it was really kind of a crazy, surreal experience. So something I've been really blessed with up to this point. So let's get into baseball here. I want to pull something else up. All right. So just quickly about the kinetic chain of baseball pitching, and even throwing. Like the throwing motion is not just all shoulder and elbow. Like it is a sequence of body movements, starting with lifting the lead foot. Then you have this linked motion through the hips and trunk, goes through the scapula, and then you take energy to the throwing arm, the shoulder and elbow in order to propel the ball. You want optimization of this kinetic chain to allow for consistent and efficient transfer of energy from the legs and the core up to the throwing arm. And this optimization is going to help you prevent injury. So if you have a breakdown earlier in the kinetic chain, in the lower body, in the trunk, in the scapula, then you're going to put inappropriate forces onto the throwing arm, and that's going to lead to shoulder and elbow injury. So here are the phases of the throwing motion. We have 6 phases: wind up, stride, arm cocking, acceleration, deceleration, and follow through. You see kind of the beginning and end of each of these phases here, where the wind up will end with the, with the leg kick. This then go into the stride phase, which ends when the foot hits the ground. We'll then go into the cocking phase, which ends as that arm reaches maximum external rotation. It'll then go into the acceleration phase that ends with ball release. Then goes the deceleration phase, which ends with maximum internal rotation of the shoulder. And then you have the follow through after that. This is just another picture that walks you through those motions: wind up, stride, arm cocking, and some of the key motions that are in these 6 phases. Here's a picture of a video of one of our Georgia Tech pitchers. So it'll walk you through each of the phases of the throwing motion. So we have wind up that is going to end with the leg kick all the way up at the top as you start to move forward. We're then going into the stride phase, which is going to end with, oh, if I can pull it up, foot contact, or pretty close to it. And then we will have the cocking phase. It's going to be as close to here with maximum external rotation of the shoulder. We're then going to move really quickly through the acceleration phase to ball release. And then you're going to go into the deceleration and follow through phases as we come through here. So those are the phases of the throwing motion. We see it's a very intricate balance, through the kinetic chain, beginning with the legs. You have a lot of balance. There's a lot of lower body strength and core strength and scapular stabilization that goes into all this. And if you have a breakdown in this kinetic chain, you're going to put more forces on the shoulder and elbow. So this is already a very ballistic motion. And if you put more forces on the shoulder and elbow than needs to be, then you're setting yourself up for injury. So the question is, what is the most common injury in professional baseball? And the answer might surprise you, but it's actually hamstring injury. So hamstring muscle injury, that's actually the most common injury across all of sports. So you think of baseball, you think of throwing arm injuries, but the most common, if you look at the sheer number of injuries, it's going to be hamstring muscle injuries. So we're not going to talk about hamstring muscle injuries, because we could talk about hamstring muscle injuries with all of these sports today, because all of these athletes get hamstring muscle injuries. And this is actually one of my primary interests is in sports right now, are muscle injuries, and how do we get better at preventing and treating muscle injuries and get athletes back faster. There's a great resource as far as muscle injury or hamstring muscle injury specific to baseball. So the contiperformance.com/educational. There's a number of episodes of this baseball injury conference that happened over COVID that are really great talks. So if you're interested in baseball medicine, go there and take a look at some of these talks. But what we're going to talk about is going to be the ulnar collateral ligament. And so this is the ulnar collateral ligament in the elbow. It's very specific to throwing athletes, specifically baseball players, as far as tearing that ligament. And it is the most common and hot button injury in baseball. So that is what we were going to talk about. So here we see, it's just a figure from a paper that I wrote with Dr. Jason Zaremski and Dr. Peter Kriz last year. And it's just a figure that just shows the number of UCL surgeries increasing. And this is with Andrew Sports Medicine from the mid to early 90s up until we get past 2010 and leading up to the 2020s. We see this significant increase in UCL surgeries for youth in the high school level. So we're seeing more UCL injuries and surgeries, and also more UCL injuries and surgeries occurring at a younger age. We see the same thing in the figure that's on the right as well. This is a poster that we presented at AMSSM last year. Jason Zrimsky is lead author, and I was on that too. We used publicly available data from online, and really our conclusion, if you look at this, is the data confirm the incidence of UCL surgeries and UCL injuries significantly increased over the last 50 years. And the most troubling part of that is that the average age of the professional players, which is what we're looking at here, that are undergoing these surgeries continues to decrease, which indicates an overuse component to this, to that as well. So there are a number of things that go into why are we seeing more UCL injuries and what is with this epidemic, and that has to do with, you know, overuse at the youth level, and then this obsession with velocity as kids get older. And so you compare overuse with higher intensity and just leads to this epidemic. That's kind of overly simplified version, but that, you know, is really, if you want to boil it all down, there are other things involved, but those are two of the main reasons why. So here's the UCL anatomy. So really what we're focused on with the UCL for this purpose is going to be your anterior band, which is going to come across right here. The anterior band of UCL is the band that we're talking about as far as tearing in throwing athletes. So just know that when I refer to the UCL, we're referring to the UCL anterior band. I'll just touch on this here. We see the ulnar nerve that's popping right across here where we see the UCL as well. Just like when you put valgus stress through the elbow, anterior UCL can also irritate your ulnar nerve. So ulnar neuritis also really common in baseball players due to that valgus stress on the elbow. So the UCL physical exam, two main tests are gold standard. Number one test can be moving valgus stress test. And then you can also do a milking maneuver. But if you just remember one test, remember moving valgus stress test. And what we're going to see here is the go-to test has 100% sensitivity, 75% specificity. You want to do this test with the hand in supination and in pronation. So think about when a thrower throws, his hand is coming through and it pronates. And so you want to do this test in pronation too to put them in a throwing position. And basically, you're going to hold the arm just like this. You're going to put a valgus force on that elbow to put some tension through the UCL, and then you're going to move while you're exerting that valgus force. You're going to move that elbow from 70 to 120 degrees, and if that UCL is injured, that player is going to feel it. So moving valgus stress test is your go-to test for UCL injuries. You can also do the milking maneuver. That's where you're going to put a valgus stress on the elbow right here. You're going to hold the elbow up just like this, and you're going to tug back on the thumb while exerting a valgus force, and that'll put some pressure across the UCL as well. You'll feel some gapping. So you can start with the milking maneuver, and then while you're milking the arm, you move them through that range of motion, 70 to 120 degrees, to do the moving valgus stress test. You can do the two of them together. So for imaging for a UCL injury, kind of the gold standard is the MRI arthrogram, and you use that contrast in the elbow to really show, what we call a T sign or a tear in that UCL. So with the contrast that goes into the joint with an arthrogram, we get a lot of players that have residual soreness just due to the injection from the contrast. And so with that soreness, we try to figure out, what can we do to, hold on one second. Good. All right. I told you I was going to get distracted. So with what can we do to give us a better picture with a non-contrast MRI? And that has become, we're able to do that now. And so for what I do and for what, other docs that I work with, who work with the Braves and high-level throwing athletes, we don't really get arthrograms anymore. We get a non-contrast MRI with a fever view. And what you see from the fever view is this position right here. It basically creates a valgus stress on the ulnar collateral ligament to make it taut, so you can really see any tears along the course of a ligament with a non-contrast MRI. So our go-to right now, as far as what I order and what a lot of other docs, and if you look at Dr. Keith Meister, who's the most prominent UCL surgeon in the country, he does non-contrast scans as well, and he sees more UCL injuries than anyone in the country. And so we do a non-contrast MRI with a fever view. And then you can also look for dynamic instability and dynamic laxity of that UCL with a dynamic ultrasound. So this is probably the best paper. It's a good review. Dr. Suter, who a lot of you may know, that does a lot of YouTube videos on injuries. He wrote this paper as part of his, I think when he was a fellow several years ago. And so it's a good paper on the role of ultrasound and the evaluation of ulnar collateral ligament injuries that he did with some colleagues at Mayo Clinic. As far as the dynamic ultrasound goes, we're going to measure the joint space at rest and under valgus stress. Between the difference between rest and with valgus stress is going to be any normal is a less than 1.5 millimeter joint gap. The stress test is positive and indicates insufficiency of the UCL ligament if that stress test is greater than 2 millimeter gap. So we see the gap at rest right here. These pictures are from Dr. Ricardo Kohlberg at Andrews Institute in Birmingham, so I want to give him credit. These are his ultrasound pictures. And this is him up here doing the test, and we'll just play the video right here. You just see him, he's just putting a little valgus force on that elbow, and that's what's going to allow you to measure this joint gap. So you take a picture at rest, take a picture with stress here. We see the UCL coming across. This is your joint space right here. I did have a video here, but it's not playing. So just a little peek at what a dynamic ultrasound image is going to look at and what we're looking for with a UCL exam. So just a few more slides. As far as magnetic resonance imaging goes, you don't have to read too much about this slide. Really what this tells us is that where the tear on the UCL occurs is very important for what is the most appropriate treatment. So a lot of you that you just hear about surgery, UCL reconstruction or UCL repair for these ulnar collateral ligament injuries, but non-surgical management is appropriate in certain cases. What we know from MRIs is that distal tears on the MRI, tears more distally at the sublime tubercle insertion on the ulna, those do not do well with non-surgical management. Proximal tears that are closer to the humeral attachment, or small partial proximal tears, or even more moderate grade partial proximal tears, more blood flow, more support from the flexor pronator mass, and they can do better with non-surgical management. So you think proximal tears, there's a chance with non-surgical management. Distal tears don't do well with non-surgical management. You can be a little bit more aggressive as far as referring those for surgery. It's not necessarily a hard and fast rule, but MRI imaging and follow-up shows us that those distal tears just generally don't do well with non-surgical management. This is a good review paper. We actually reviewed it as part of one of the AMSSM journal clubs last year, non-surgical management of ulnar collateral ligament injuries. And this table is a good one to just for generalization tells you, a grade 1 is a mild tear, grade 2 moderate, grade 3 is a complete tear. And you can see with the tear location on the MRI, as well as the grade, when is non-surgical management appropriate and when is referral for surgical management indicated as well. And part of non-surgical management, it's not just the rehab process, is do we include a PRP injection or not? So that's the next question is non-surgical management or surgical management based on, so we say we have an athlete, he's a second baseman, he has a small partial proximal tear, we are going to pursue non-surgical management. Do we PRP this ligament or do we not PRP the ligament along with the rehab? And my take on that is we definitely PRP the ligament based on, not that we have high level randomized controlled trials, because it's just not going to happen in this population. No athlete's going to sign up and say, okay, you can give me a sham injection into my UCL and I'll do some rehab while another group gets PRP. It's just, it's not anything that I think is reasonable and is ever going to really happen. So we have to extrapolate a bit. So this is still from 2013. Luca Podesta, who's kind of a guru in the baseball world, especially the non-surgical baseball world. And this paper's from 2013, American Journal of Sports Medicine. We have 34 overhead athletes, partial UCL tears. They had already failed at least 2 months of rehab, and these were proximal tears as well. They'd failed 2 months of rehab already. So they did too much rehab. They tried to start throwing again. They still had pain. They went back, did a PRP injection, then did another course of physical therapy, and they were able to return to play. They followed a 12 to 14 week rehab protocol after the PRP injection, and the average return to play was 12 weeks, and 30 of the 34 players were able to return to play at 12 weeks after that. Only one of these players went on to have surgery. And then we also saw significantly decreased medial elbow joint space opening on ultrasound with valgus stress. This is conformational ligament healing. Now, this is not the only paper by any means. Just for time's sake, this is the only one I'm going to talk about. I have whole talks on this topic, PRP for UCL injuries. But based on the totality of the evidence, and we've written a review paper on this as well, then I think if we're going to pursue non-surgical management, then a PRP injection into the UCL is very much indicated as opposed to rehab alone. This is just a clinical bottom line, Journal of Sports Rehab. I'm going to read it real quick, and then that'll kind of drive the point home on this. And it says, current evidence suggests that the addition of PRP to conservative treatment may improve outcomes in overhead athletes with partial UCL tears. Athletes whose treatment included PRP show higher return to competition rates and shorter recovery times before returning to competition compared to athletes who just had rehabilitation alone. And additionally, athletes with grade 1 to grade 2 proximal tears return to competition rates comparable to athletes undergoing surgical intervention. So those are really the key points I want to drive home with this, that really highlighted well in that clinical bottom line from this Journal of Sport Rehab review. So take home, UCL injury treatment, non-off-bridge management, physical therapy, and PRP for partial tears at the proximal or humeral location. You can be a little more conservative with this with a fielder in that you can do, a higher grade tear. You can probably still pursue non-surgical management in the fielder versus a pitcher. And non-op management can be definitive in the correct situation if you really understand the literature and know how to select the appropriate athlete for non-surgical management. Average return to play based on the literature is about 12 weeks. In real life, it's probably longer than that, but based on the literature, 12 weeks. But, if I have time, I definitely give athletes more time than 12 weeks to get back. And then surgery, UCL reconstruction or repair, that's appropriate with complete or high-grade tears and also tears at the distal or the ulnar origin. These are a couple papers that we've written recently that are related to this topic and may be interested. Orthobiologics for the treatment of throwing-related injuries. That primarily is going to be on PRP injections for UCL tears. So if you're interested, take a look at that paper. And then also this just came out in the Journal of Osteopathic Medicine. There's an osteopathic component to this in one section, but there's also just a full overview of elbow injuries and throwing athletes that I think we did a good job of really doing a good summary of those injuries. And so that just came out in November. If you're interested, take a peek at that. Long form discussion of a lot of these topics. I did one of the fellows online talks last year in March. It says 23, but it's actually 24. So an hour-long talk. If you're interested in this topic, go back and take a look at that. And thank you for having me. I appreciate it.
Thank you, Dr. Bowers, for your excellent presentation. Now it's my pleasure to introduce Dr. Aaron M. Lear, who will make a presentation on softball. Dr. Lear is a sports and family medicine physician with the Cleveland Clinic at the Akron General Site in Ohio. He has been in practice for 17 years, caring for all levels of athletes and patients in the office and on the sidelines. You can go ahead and share your presentation now, Dr. Lear. Thank you.
All right, great. Thank you. I am going to talk about softball. Let me get the presentation up here. Okay, so I'm just going to kind of follow the script that we got about kind of how we got involved in the in this particular sport, and then just kind of run through common injuries as you just saw with baseball. And as with baseball, I'm not going to talk about the common injuries. I'm going to talk about the pitching stuff just a little bit, and then spend a little more time on examination, and just a little bit on the rehab. And really the way I got into softball was lucky. I took a job. I did my fellowship at the Cleveland Clinic and took a job about an hour south at a family medicine residency program that was looking to add a sports medicine trained doc. And one of the docs there happened to be taking care of the professional softball team in town. It's a now defunct pro softball league called the National Pro Fast Pitch. Akron was one of the founding teams and stuck around while many teams kind of dropped in and out, folded and restarted. There was a team in Chicago that stuck around through the end, which happened in COVID. So COVID kind of crippled the I guess income of the league, and it folded. And so there is a kind of, I think it's called players unlimited professional softball now, and that mostly happens at one place. The players kind of swap teams daily or every other day, or every few days or week or so to play on different teams, and then I don't really understand all of it, but they get ratings based on their level of play individually. And I have to say that I loved it, and I was sad to see it go. I loved the players. They were no nonsense people. That most of them were within their first few years out of college, and they would kind of do their coaching during the school year, and then come play pro softball in the summer for 2 or 3 months. They were dedicated people. They worked really hard. They were not prima donnas. They were funny and really enjoyable to be around. I had a great time with it. And so as I got involved doing this, what I learned was that there's very little written about softball. And as Dr. Bowers, I'm sure can attest, there is mounds and mounds and mounds written about baseball and baseball pitching. There's a lot more now than there was 10 years ago about softball, but there just isn't nearly as much about softball. And so it was an easy opportunity for someone that was kind of interested in research and interested in doing a little bit of writing to start to do that. And so with some of the residents coming through who were planning on doing sports medicine, we did a little bit of research and a little bit of writing about softball, and have generated probably what I would call an undeserved reputation for expertise in softball. But there aren't many people doing it. So if you want to get famous in something, do find something that no one's doing, and get into it. We're going to spend more time talking about pitching here, and kind of follow the biomechanics here. And this table is from an article we wrote about softball pitching and injury that was in current sports medicine reports. And I have a list of references at the end of the talk, and there's also, I dropped the PowerPoint or a PDF of the talk into the chat if anybody's interested. So softball is very different, and I'm actually just going to kind of pop us over to the next image here. And this is just a YouTube video of Jenny Finch, who is probably the most famous American softball pitcher. She's played in the Olympics. She played in the NPF when I was covering, and I think that she played for a team from Florida that seemed to have more money than everyone else, so they could sign the bigger players. But you'll see that, I mean, obviously this is a lot different than baseball, and it's more of a kind of vertical. It's referred to as a windmill pitch. The sort of beginning, or that sort of wind up or cocking phase, is different for everybody, but you can see her go back almost to 90 degrees in extension at the shoulder, and then spin around. As people spin around, they transfer their weight forward, and the ball, there's very little flexion and stress on the elbow. Although when people measure this biomechanically, they measure sort of forces that are similar to what people measure in a baseball pitcher. I don't really understand how that's possible, but this is sort of consistently seen in biomechanical evaluations of softball. What's true about it is that people don't have the same kind of injuries as one might expect that baseball pitchers do, or that overhead throwers do. And most of the softball injuries that I would see are overuse injuries. And so we're going to I'm going to just go back one slide here. I'm going to move, I'm sorry, the transcription's showing up over the screen here. So you see this wind up, and they start there. They sort of lean backwards, and then transition forwards as they're moving their arm in this large circle. Again, as I said, the elbow has very little flexion, and there's very little valgus stress that you can see if you look at it. But it is kind of measured and seen in there. The pitchers also will do a lot of kind of twisting with their wrist and forearm as they release the ball, depending on what kind of pitch they're throwing. Notably, there's also not a large deceleration phase in softball or in the windmill pitch as compared to a baseball pitch. So it's, at least it's my understanding, that some of the deceleration, are going from throwing really hard to having to stop really quickly, seems to be some of the impetus for softball injury. I'm sorry, for baseball injury, which is not seen with softball. So just briefly about what the injuries are. In the papers that we've written about this, and in most of the data, which is a lot of it is NCAA injury surveillance data, and then there are some national level kind of high school injury surveillance data. And there does seem to be some difference that high school kids get hurt more often in practice, college kids get hurt, and professional players get hurt more often in games. The question of acute versus overuse injury tends to depend on what positions you play. Catchers with their overhead throwing will get overuse injuries in the shoulder. Pitchers will get shoulder and elbow injuries, often hip injuries because of the weight and the transition. It seems true, but the most common injuries in softball are in the same way that they are in baseball: ankle sprains. So running the bases. It's also true that there's a lot of injuries from batted balls. So fielders will get hit in the head and neck and get injuries like that. Getting hit in the hand and wrist by the ball is another common injury. Concussion seems to show up more commonly in some of the literature. I didn't see this consistently when I was taking care of professional softball players. It was a really uncommon injury. But again, most of these are just acute sports injuries, twisting your ankle on the bases, getting hit by a ball that takes a bad hop, this kind of stuff. And so being able to take care of any injury is being able to take care of most injuries in softball. It's when you start to get into the pitching stuff that you need to have a little bit more attention to it and understanding of it. One thing that we didn't talk about or didn't hear about in baseball that I just wanted to mention was skeletally immature athletes. So if you're taking care of kids and little leaguers, you will see growth plate injuries around the shoulder and elbow with a lot of throwing and a lot of pitching. It's not only true in the shoulder and elbow, certainly, but if we're talking about pitching, and it goes by the name Little League shoulder and elbow, this is often visualized with x-rays. You can see some widening of the growth plate after you've examined the kids. So it's usually in their proximal humerus, and typically they are tender around the proximal humerus, sort of at the transition from the proximal humerus into the humeral head. And this is different than you'll see usually with just tenderness around the shoulder, so directly around the shoulder joint. And that's how I'm often kind of determining that when I'm thinking about it with kids. I have seen a lot of internal rotation injuries or subscapularis kind of tendinitis or overuse injuries, which is not a common injury I see in anything else. This overlaps a lot with proximal biceps tendinitis. So the long head of the biceps at the shoulder can get quite inflamed with repetitive windmill pitching. You can also see that at the elbow. So you can get the distal biceps tendinitis also. And so these are things that will show up a lot more in softball pitchers. And then the last thing I wanted to talk about, because we heard a lot about the elbow and UCL injuries, not common at all with softball pitchers. You can see it with overhead throwers. It does happen, but it's not. I didn't see it in my practice at all. One thing that I did see a fair amount of that I just didn't get taught about or couldn't find in the literature was thoracic outlet syndrome. And I think we heard Dr. Bowers is kind of interested in this neurologic thoracic outlet syndrome or peripheral nerve injury. This was something that I saw quite a lot, and it tended to be a vascular variant in the softball players. And we would see them pitch, and their arm they generally have a really hypertrophied shoulder and arm anyhow, the pitchers, compared to their opposite side. As they pitched, you could see the kids or the women that had it, their arm would swell, and they would start to get kind of numbness and tingling and a sort of deep ache or throb through the game. Most of them could get through the game with it. Some of them had been diagnosed with it before they came to us. And none of them were willing to kind of go through the process of having surgery. It was stuff that we just managed with therapy kind of through our through the season, and then just kind of dealt with dealt with it on an as needed basis. One more thing just quickly that does tend to happen a lot in softball because of the back extension or loading with pitching. We had a really low threshold for looking for a stress fracture or spondylolysis in the low back, and saw a fair amount of this. And what we saw at the professional level were women that had that injury earlier in life. and just had a kind of chronic pain with it, and it would fire up from time to time. And we didn't really kind of go through the whole process of imaging it with MRI and then shutting them down. It was just a management of the chronic pain that they had from this injury that was present many years ago. With kids coming into an office, if you're seeing sort of middle school and high school kids playing softball and they're getting a lot of low back pain, this is something to definitely be aware of. And one more thing I wanted to talk about, and this is just, I was involved with a writing group or a kind of group at a youth sports conference that AMSSM ran a few years ago. And these are the other people in the softball group. Susie McNulty, that's in there, is very involved in softball in California. She played in college. She coaches now. She has kids playing in college. And she was very involved with sort of high level travel softball or whatever you like to call it. Because they had a girl on their team take her own life, she got very involved with mental health. And so we did a lot of work with this as part of the follow-up to this youth sports stuff. And it seems, and this is more anecdotal, our research did not bear out the idea that what we thought we would see is that kids that were more specialized and that were playing a lot more often would have worse mental health just on screening tests. We did not see that. We actually saw the opposite, that kids were very involved or rated as highly specialized had lower levels on the PSQ-9 and the GAD-7. But she maintains that there is a really significant level of emotional distress or mental health distress in a lot of kids at high level, not just softball, but high level sports. And so it's just worth paying attention to and being aware of kids getting highly involved, or if you're seeing signs of them kind of just not looking like they're enjoying their sport, being overly anxious, etc. Just pay attention to it and ask about it. And that's all you have to do. I'm going to just go through a couple quick physical exam things here. I just popped these into the talk. So you like Physiopedia and PhysioTutors are both two good websites to go through for physical exam stuff. And some of the images we're going to look at here. I also did have a video in here for the dynamic valgus stress because I talk about that here. So these are just pictures for these exam techniques. For the dynamic valgus, I put this up here for the UCL. I'm not going to talk about it a whole lot. This is actually a bit of the milking maneuver and sort of transitioning into the dynamic valgus. The three tests that people are often doing for subscapularis, apart from just an internal rotation test at the rotator cuff, is this. They call it bear hug. I would just call it cross arm adduction. The belly press test, where you put your hand on your belly and you try and push down while bringing your elbow forward, and then a lift off test posteriorly. These are all useful for subscapularis and can isolate this pretty well. It's probably the least injured rotator cuff muscle, but the most commonly the one with the most tests because it's easily isolated. Biceps tendonitis, both at the elbow and the shoulder. It's a little bit hard to examine for. I find speed sign to be a really helpful, useful thing, both at the elbow and the shoulder. This is the image on the right with your shoulder forward flexed, palm up, and the physician or the examiner pushes down on the palm while the patient resists, and pain at the anterior shoulder is a positive sign. Jurgensen sign, also for proximal shoulder proximal biceps / labrum. I also use it for distal biceps. And in this case, the patient is pronating or turning their palm down while keeping their elbow flexed. And the examiner is trying to supinate or turn their palm up while pushing down on the forearm. So trying to push the elbow into extension. A positive at the shoulder is usually a positive it's intended to be for labral tear. I use it for biceps since the biceps attached to the labrum. You also can see this with at the distal biceps at the elbow. Thoracic outlet syndrome is a really hard thing to be good at because you just don't see a whole lot of it, or at least I don't see a whole lot of it. I tend to use this resource, DeLay, Dresden Miller Orthopedic Sports Medicine. They have a really nice section on this with good images that I'm going to show you here. And all of these are trying to put the patient in a position where you're either compressing the artery, vein, or I guess the neurovascular bundle, the nerves coming out, This is Adson's test. Patient's head turned toward the shoulder, and you can see the physician testing for the pulse, and the pulse disappearing with the change in head position, and with the arm extended. This is Rue's test. This is, I like this one a lot because what you're trying to do is get the people's hands above their shoulders and just open and close their hands over and over again. Patients don't like to do this because you're meant to do it for about a minute. So I usually do it with them to see if it causes their symptoms. The costoclavicular maneuver here, the patient retracts their shoulders. This is again to try and recreate symptoms, to put your patient in a position where it compresses their neurovascular bundle. Supraclavicular test, you're compressing that sort of postclavicular recess where the neurovascular bundle runs, to see if you can recreate symptoms. And then the right test, this is just another way to decrease the pulse overhead or recreate symptoms. And so this is just something to be familiar with. Know a resource where you can go find those things. If you can get your hands on that book, we access it through Clinical Key, which is a resource our library has. And that book is available there, and they have a really good chapter on thoracic outlet syndrome. So treatments, I didn't go into this a whole lot because I'm already kind of talking a little bit long here, but usual treatment for usual stuff, ankle sprains, usually you're just doing rehab, bracing, etc. Facial fractures, that kind of stuff, you're generally going to be doing, or facial injuries, emergency room, CT scan, lacerations, etc. Thoracic outlet syndrome is a tough problem. It can be a surgical problem, which is usually referred to vascular surgery. Occasionally, people will do things even like remove the first rib if necessary. The workup for that after the clinical exam is usually some combination of EMG, ultrasound, or CT angiogram testing to try and delineate neurovascular or neurologic versus vascular, and then referring on to the right specialists. Usually, we start with rehabilitation before surgical intervention. And then the bony overuse injuries like little lead shoulder or elbow and spondy. This is usually rest for about 2 to 4 weeks. Once they're feeling better, slow rehab and return to play, depending on how they're returning. Here's my references. That's it. Thank you.
Thank you, Dr. Lear, for your outstanding presentation. Now it's my pleasure to introduce Dr. David Olson, who will be presenting on football. Dr. Olson is a primary care sports med doc in Minnesota, fellowship associate director at University of Minnesota program. He is also a team physician for the Minnesota Vikings, Minnesota Twins, University of Minnesota, University of St. Thomas, Roseville Area High School, and U.S. Soccer. Dr. Olson, you can go ahead and start your presentation.
Awesome. Hopefully everyone can hear me. It's very nice to be here and be hanging out with everyone on these talks. Great to hear all these talks so far. So it's also nice to have the guy on that just was getting his butt kicked in the playoff game last night when we played the Rams. So this will be good to be home and give a talk and hopefully give you a little information here. So I'm going to talk about football. And I'm going to get rolling through this because I know we're a little behind now. I don't have any disclosures myself. Football, really, I'm going to go through just a little history of it. Really, the roots of football are in soccer and rugby. And it really started at elite American universities and was sort of a rowdy student-run game. Didn't have a lot of people overseeing things, and then sort of developed more formally, but first really began as an informal type game. So the first noted football game was played November 6th, 1869 in New Brunswick, New Jersey, and was a match between Rutgers and Princeton. And the rules they took were from football that was played over in London, in England, and again was more of a soccer style football game. This person here, Walter Camp, was really known as the father of American football. He played at Yale in the 1870s and 1880s. Interestingly enough, for our group here today, he was an undergrad at Yale, but also became a medical student at Yale and went into medicine. And he really was the voice of sort of helping set up rules, which really became more to deal with safeguards and to try to make American football safer overall. So with football, how did I get involved? I think as you've heard from a lot of our speakers, a lot of times you've played the sports. So I played football, basketball, and baseball and really loved all of those sports. And then it was cool when I was in medical school, I got a chance to hang out with some docs that were doing sports medicine kind of activities. And I knew I wanted to go into primary care. I'm a family medicine, sports medicine doc. And in doing some rotations, I got to hang out on the sideline at high school football games, see some injuries, take care of some athletes. And I just thought it was the coolest thing ever. So that really sparked my interest in sports medicine and in football coverage in general. That experience really got expanded in residency, doing more rotations where I got to hang out with docs and do formal rotations in sports medicine and cover more football at a high school and college level. My fellowship year I did at Notre Dame University, so got to hang out and do the football coverage there. And that really got me to feeling like I really want to do high level football coverage. So then I've been lucky enough to do sort of football at all levels in my practice, covering my local high school team, which is so much fun. Really not much better out there coverage wise than Friday Night Lights and high school football, but also hang out at some colleges here, University of Minnesota and St. Thomas University, as well as working with the Vikings in the NFL. So when you look at football and talk biomechanics, first, I'm just going to talk a little bit, like I said, with the history of football. You know, football was rough. It wasn't just, you know, you're spraining your ankle or doing this and that, but there's actually a lot of fatalities in football at first. And that was because player to player contact is really the biomechanics of football injury, and still is today a lot of times. At first, they were doing these large groups of flying V wedges where one team was having the ball and just basically running through the other team as fast as they could. So really you had to put together groups of people, and Teddy Roosevelt actually called a meeting to help save football because they were going to shut it down because of all the fatalities. Unfortunately, we still see fatalities in football, and these can be from cardiac, it can be brain injury, concussion, trauma kind of things, but also heat illness, sickle cell trait can play a role in things like that too. So when we look at football, and the different injuries, we really need to look at rule changes to help make football safer overall. When we look at the basics of football and injury types, you see a little bit of everything. You can have upper body injuries, lower body injuries. I think one of our earlier speakers talked about when do injuries happen. In football, preseason injury rates can be a lot higher than in season and postseason, just because the numbers of people that are practicing, the amount of time that you're playing and practicing. So really that preseason time for us can be a very crucial time in figuring out how to take care of our teams and to do so in a safe manner. In that time, we also, on top of knee injuries, ankle injuries, we see a lot of concussions and other soft tissue injuries. When you look at things, again, player contact is really the number one mechanism and cause of injury in football. And it can be position dependent as well. If you're a running back, you get the ball and you run and everyone's trying to come and hit you, as is, what also happens with quarterbacks. Those can be very dangerous positions and a lot of injuries can happen in that way. So when you're covering football, I think the fun thing about it and the thing I like about it the most is that the injury profile is a little bit all over the place. So you have to be good at a lot of things when you're covering football. You can see cervical injuries, again, that can be catastrophic if they're not taken care of appropriately. Fractures, dislocations. I love dealing with fractures and relocating dislocations and things like that. You can have severe organ injuries too. So you really have to be on top of things when you're covering football. A lot of times for us too, in the professional or collegiate level, you're also trying to decide if you have injuries, can that player travel or not travel? And looking at things like lung injuries, can they get in the plane and go to altitude, different things like that. So all kinds of things that go into play with return to play, but also just trying to figure out what's safe for players to do or not. So what I'm going to talk about are concussions. Again, you could have a whole conference talking about concussions. So in 10 minutes, it's just going to be a little quick synopsis here, but I'm going to talk about that for a little bit of a focus here. And what I want you to do is to take some of the stuff that I'll talk about and then try to look into it a little more, look up some of the exam stuff that you might do, some of these protocols that are out there for concussions as well. So concussions, most common head injury, we see it a ton in sports. So when you look at overall sports injuries, concussions can be anywhere from 6 to 10% of those injuries. You can have helmeted and non-helmet. It doesn't always just happen in football. You can have head-to-head, helmet-to-helmet contact that causes concussions, but you can also have whiplash injuries and non-helmeted injuries that can cause concussions. Sometimes this can be because of poor equipment, can also be a technique issue. So sometimes tackling and coaching how to tackle properly and things like that can also reduce some of the rates of concussions that we're seeing. When you look at concussions, exam skills, again, first and foremost, you have to do your ABCs on the field. You have to make sure it's a concussion and not something more serious like a head or neck, a spine injury. So we always, when we're suspecting concussion, start with looking for red flags. That can be neck pain. Is someone having seizures? Do they have visual disturbance? Was there loss of consciousness? Other neuro issues, especially if they're having neurological symptoms in bilateral extremities, vomiting, other things that could show us that it's more than a concussion and potentially a brain bleed. So really, you know, when you're on that sideline, one of the most important things to do as a physician covering football is get around and be able to see things. If you can see that mechanism of injury, it might give you some clues as to what's going on with that athlete. So observable signs, and when I talk about that, that's saying, is someone, you know, staggering after a hit? Were they posturing? And we see this in football and gets replayed over and over again. Did they run into the wrong huddle? So you got to look to see, you know, after a big hit, not all big hits cause concussions, not all hits that even don't look big can't cause concussions. So you really have to try to look and see if there's something that you're observing when you're covering that gives you a clue that an athlete might be, you know, struggling from concussion type symptoms. Then I'm also talk a little bit about clinical exam, Maddox questions, SCAT, and impact here too. So a lot of times when we first get that athlete in the NFL, we have the fancy tents, but if I'm at my high school, I might take the athlete over the bench and just go over some of these Maddox questions. And that's simply asking, you know, where are we playing our game at? What half is it? Who scored last? Who did you play last week? And did you win that game or not? This gives you a little idea on how they're functioning. And it's not always just the response, but how they're processing it. And one of the big things in sports medicine too is getting to know your team. If you know your team, if you know the players, you get a little bit of a sense on if that athlete's acting like their normal self or not. SCAT is something I want you to check out. So the updated SCAT 6 is out there. And this goes through a symptom checklist, goes through these Maddox questions, but also tests a variety of functions like memory, balance, concentration, coordination, and recall. And these are things that we'll do with an athlete on the sideline, you know, in our locker room to decide if someone can go back to play. And then there also is computerized neuropsych testing like impact and other things that can look and give you an idea more so in the return to play area of concussion and see if someone is getting back to their baseline. So looking into those things can be good. There are, you know, I think you're seeing more and more of things to try to help decrease concussion. So guardian caps are out there. The NFL did a pilot with these showing some reduction in concussion. These were used at first in sort of our training camp preseason spots. Where we were seeing the highest rates of concussion, but now even in the NFL, you see players wearing these during the game. So more to come, I think, on some of these things, but you know, for a long time, people have been looking at helmet design and things like the guardian caps to see if we can help players in football participate in a more safe way. When you look at return to play from concussion, you know, a lot of times initially it's resting and recover. It's close follow-up to see how they're doing as far as their symptoms and doing some of that testing like I talked about with the SCAT testing or computerized testing. And then one thing we know now that, you know, years and years ago we weren't doing, people were sort of resting for a long time or, you know, being in a dark room and things like that. Now we know that early introduction to activities that don't increase symptoms, but give you a little aerobic activity and stress the brain a little bit can be a helpful thing in that recovery process. And then what we do is a gradual ramp up over a number of days as people are able to progress through these different steps and get back to the activity that they want to get back to. And as we ramp that up, it's usually a day at a time, first starting with simple things like light aerobic activity, getting into a lift. And then, if they've done that well, the next day they could do sport-specific activities. After that, non-contact practice, and then getting back to full practice and game activities. So it's really this organized protocol of a ramp up day by day of activities, as long as they're not having a return of their symptoms. If they are, then sometimes we do need to take a step back. And with that too, we have a lot of other people that are helping us with that return to play now. There's organized concussion physical therapy that can help work on things like eye problems, vestibular problems that might be making people hold on to some of their symptoms, and that can help them get back, more quickly and safely to their sport as well. One plug I'll put in is for emergency action plans. These are vital, and especially with some of our head and neck injuries. We've seen these in action in the NFL, both for concussion issues as well as cardiac arrest, which we saw with the Bills a couple years ago. You need to review these. They need to be updated. You need to run through and practice these things with your team that's going to be at those games. And then you really, just need to get out there and, like I said, be ready and equipped with some of these skills to have when you're covering football on the sideline. And I will hand it over to the next speaker now. Thank you.
Thank you for that excellent presentation. Now it's my pleasure to introduce Dr. Ashley Austin, who will make a presentation on basketball. Dr. Austin is a former college basketball player who is board certified in family medicine and sports medicine. She has covered sports at all levels, including high school, NFL, MLB, WNBA, and the National Ski Patrol. She currently serves as team physician for the New York Liberty in Brooklyn, New York. In her free time, she enjoys high altitude mountaineering and hiking in the summer, snowboarding in the winter, and playing and watching sports year-round. Her sports medicine interests include radiofrequency ablation for chronic knee pain and injury prevention in women's sports. You can go ahead and give your presentation now, Dr. Austin.
Awesome. Thanks, Kylie. All right. Last one, you guys. So I'll try to move through quickly so we have some time for questions. I don't have any disclosures. So I'm going to just do just a quick overview. Will be very similar to everyone else's presentations. Just talk about how I started with the sport, some biomechanics of the sport, the most common injury, clinical presentation, physical exam, and then ending with treatment and the return to sport. So my involvement in basketball, as this has been echoed throughout this talk, but a lot of us had the same story as we were involved in these sports, and we kind of grew with them and kind of made our careers around them. And so similar for me, I played Division I college basketball and at the University of Evansville, which is in Indiana. And then thereafter, I really was interested in continuing to work around basketball, and I had always known I wanted to be a doctor, so it kind of matched my interest there. I ended up studying family medicine and then went to the University of Washington for fellowship, where I stayed on and took care of women's basketball there. An interesting opportunity came up in 2020 when a lot of the sports teams were going into bubbles. I was able to work in the WNBA COVID bubble, so I spent a month down in Florida, and I was the team doc for all of the teams, which was very busy. But I was one of the docs that got to rotate down there, which was a fantastic opportunity, unforgettable experience. And then now I'm the team physician for the New York Liberty here in New York. So biomechanics of basketball, I have just like a very just general overview. As with a lot of these sports, we use nearly every muscle, bone, ligament, joint in our body when we're doing these sports, but just thinking about overall the movements that are happening. So, basketball is a series of runs, there's quick sprints, and there's a lot of acceleration and decelerations. There's also a lot of jumping and skills work. And a lot of times you're combining things. You're jumping and shooting as a skill, you're dribbling and running and stopping and starting. So there's a lot of like complex movements that are happening at one time. There are also other things, just thinking about injuries and things like that. There is strategic contact, very similar to like something like football, where, with every snap of the ball, you're making strategic contact to try to advance the ball down the field. Similarly, there's strategic contact in basketball, setting screens, boxing out when a shot goes up to get a rebound, and all these things can introduce opportunities for injury. So in this way, the athletes are, exposed to opportunities for both acute and overuse injuries as well. As we see in a lot of our sports, there are the contact aspect where there's direct contact happening, and there's also non-contact. And basketball specifically has some opportunities for non-contact injury where people are just changing direction or changing speed and things can happen. Especially in women's sports, we think about ACLs and knees and things like that. So common injuries. So I thought I'd break it down just high school and professional. So for high school, there's a study done in 2021, and it kind of looked at high schools across the country and the most common injuries by sport. And so for women's basketball, the most common injury was the knee, but a close second was the ankle. For men's basketball, it was the ankle, and the second was more face, head, and neck injuries, and that would include things like concussions, dental issues, face lacerations, things like that, that can happen just with a lot of contact. And so the thing that I'm going to focus on is the overlapping injury, which is ankle for both the sports. So if we look at the NBA and kind of with basketball, we'll cover both NBA and WNBA. So for NBA, there was a couple studies that have been done. There was one done in 2010 and one done in 2024. So, basically 14 years later, what we're finding is that the most common injury that's happening is still ankle sprains, regardless of it being, 14 years later. That study in 2010 looked at almost 20 years of data. So, the game hasn't really changed. It's changed a lot, but not in the ways as far as injury patterns that we see. The important thing to note here is though the ankle sprain is the most common injury, the injury that takes players out for longer periods of time are things like injuries to the hand and wrist. So that's also important to note is just because, you have a common injury doesn't mean that injury, and specifically for us talking about ankles today, the rates are very high for having ankle sprains, but the loss, the return to play is actually reasonable, and the lost time is not as much as other injuries. So for the WNBA, similarly, there was a study done in 2020, and as was mentioned about softball versus baseball, very similarly, NBA versus WNBA, there's a lot less data that we have on WNBA and women's sports in general, but also just women's basketball compared to men's basketball. So there was a reasonably good study done in 2020 that looked at injuries in the WNBA over a 5-year period, and the lateral ankle sprain or the ankle sprain was the most common injury. The second most common, as I alluded to earlier, was an ACL tear, which we see, and usually these are non-contact where there's a quick change of direction. So some risk factors for ankle sprain, which we'll be sort of talking about today, player position and movement mechanics. So where they are on the court, are they a guard where they're getting a little bit less contact? Are they forward or centers where they're more down low and mixed up with bodies more? The volume of games. A lot of the WNBA extended their season by 4 games this year. And so it'll be interesting to see how the volume of games determines what kind of injury patterns we see, because we definitely saw higher injury patterns during COVID where the season was shortened and they played more games in a shorter period of time. We'll also see that on Olympic years where they have to squeeze more games in a shorter period of time. Training loads, so how they're preparing during season and post-season. And are they overuse, is there a risk for overuse? The intensity that they're playing. Some athletes, as any of the people that talk today could tell you, they just play with such an intensity that if, when they get hurt, they get really hurt. And so that is certainly a risk factor. Recovery time between games I alluded to, and then surfaces. I have some athletes that know when we play in Connecticut, not all hardwood courts are considered equal. And so, for instance, they'll say, Connecticut has, they'll come out with, everyone's got knee pain and back pain after playing in Connecticut because they feel like the court doesn't give as much as it does in other arenas. So that's important as well. So diagnosis of ankle sprain, generally clinical presentation, it's acute onset of an inversion or eversion event. The picture at the very top shows an inversion, so the ankle inversion. It can be an audible or a perceived pop, stretch, or pull. There can be swelling or ecchymosis, so bruising. There could be tenderness over the ankle ligaments. I mentioned several of the ankle ligaments that are involved. On the medial side of the ankle, there's also the deltoid ligament, which is a big ligament. But it's got 3 different bands, so it's usually not as commonly injured. But the most commonly injured is the anterior talofibular ligament, and it's also the smallest, so it's the most vulnerable. So when we're inverting our ankle, we're almost always catching this, what we call the ATFL. Usually people are having pain with passive range of motion of the ankle. They usually have decreased strength when you're testing the ankle in the various planes of dorsiflexion, plantar flexion, eversion, and inversion. They can have a positive anterior drawer test. So this is the anterior drawer test on the lower side here. And basically what that's showing is we are essentially stabilizing the tibia, and we're anteriorly translating the talus for the tibio-talar joint making up the ankle. And that's a test for the integrity of the ATFL ligament. And we're also just evaluating neurovascularly. In really bad injuries, sometimes they can get enough swelling to, lose pulses to their feet, and, develop things like compartment syndrome and things like that. That's pretty hard with ankle sprain, but not impossible. So those are things we're looking at. The other thing we're looking at is we have this membrane here called the syndesmosis. So when we think about ankle sprains that take a really long time to heal, usually these are high ankle sprains where this membrane is disrupted, and that generally takes quite a bit longer to heal. So they're going to be on the longer end of ankle recovery. So for imaging, typically we're using the Ottawa ankle rules, which are been around for a very long time, and obviously our clinical suspicion, rules over everything. But ultimately, we're getting radiographs on people who, they are not able to, if we're following the Ottawa ankle rules, walk at least 4 steps after an ankle injury, or they have any bony tenderness. So that's the lateral malleolus, which if you look down here, lateral malleolus, medial malleolus, or if they have pain along the base of the fifth metatarsal or the navicular bone. These are common places where people can have injuries with ankle inversion events or eversion events. And so if they have any evidence of or concern for bony injury, we're usually getting an X-ray. If an X-ray is negative and our suspicion is high, then we're generally getting an MRI for these people. So this is an example of an MRI. And on MRIs, we can see the extent of, the severity of the ankle sprain. We can look for bone contusions or swelling in the bone. We could see which ligaments and how bad the ligaments are injured. And we can also look for underlying fractures. It's important for ankle sprains or suspected ankle injuries to do the exact same physical exam every time. I can't stress that enough, because people can have an ankle sprain and they can also, have a fracture of the foot. And if you're not doing your foot and ankle exam together every time, you can miss something. And so that's also very important as well. So down here, you can see the grades of ankle sprains. When we say this is an intact CFL ligament, or the calcaneofibular ligament, this is a grade 2 injury, so it's partial tearing. And here you can see that there's there's no attachment here. So it's a full grade 3 tear. So when we say ankle sprain, it could mean a grade 1, which is a stretch, a grade 2, which is a partial tear, or a grade 3, which is a full tear. So treatment for ankle sprain. So way, way, way long ago, it used to be that we just really immobilized people. We didn't have them walk, and they spent a lot of time off their feet. Now there's an element of active rest and active recovery. So usually we're doing ice compression elevation, for the first day or 2, but ultimately we're trying to find a way for people to move. So we're doing anti-inflammatories for swelling and discomfort. We're doing immobilization. This could look like an ankle brace. This could look like ankle taping. These are ASO braces, which I really like. Or we could use something like a walking boot if it's significant enough to where they can't put any weight down. Occasionally, they're severe enough where people have to use crutches with a walking boot, but ultimately within a couple of days, you're usually able to wean off the crutches and then just walk in the boot. And the boot is really just offloading them, but allowing their ankle to move, to help with decreasing the swelling and to help with blood flow. That's helping with recovery. Early ambulation and physical therapy are key. So for return to sport, this was actually a recent study that was done in the last year, and this was done by Smith et al. And this basically outlines a nice consensus statement for return to sport for ankle injury. So ultimately, the things we're looking for are, we want to know that their pain and severity has decreased. We want to know that they have an improvement of ankle range of motion and ankle strength. So these are the things that we're working on in therapy. So range of motion, strength, so early mobility, range of motion, strength. This is being included in a lot more protocols. Athlete perception, how do they feel? What is their confidence that they can do the things they need to do to return to sport? Psychological readiness, this alludes to the mental health aspect we were talking about. Your body can be ready to play, but really making sure the mind is following as well. And then the last thing we look at are things like proprioception. So this would kind of look like we're doing, our ABCs to work on range of motion. Then we're getting bands and working on strength. And then we're doing proprioception, which are balance activities. That's usually the last thing to come back. So that'll be on an uneven board or a ball, a half moon ball where people are balancing. And ultimately, this posture control and dynamic control is important before you're returning to sport, because when you're doing sports where you have complicated movements, you're not looking at your ankle during that time. You're up and doing dribbling and shooting and doing all these things at once. So you really need your body to understand where your ankle is in space. And once the ligaments have been stretched, the body needs to sort of reset. So that's the process that's happening. So once that looks good, then people go into sport-specific function, which are things like hopping, jumping, agility work, sport-specific movements, getting ready back to play, and then usually practice and then gameplay. Generally for mild ankle sprains, grade 1, this is usually 1 to 3 weeks. Grade 2, usually 2 to 6 weeks. In grade 3 or high ankle sprains, it can be up to 12 weeks, depending on how severe it is. There is also just a plug for secondary prevention. So there are some studies that show that when someone has had a history of an ankle sprain, if they do wear an ankle brace, there is an element of secondary prevention they can have, not if they have never had an ankle sprain before. So only if they've had an ankle sprain. And that's all I have.
Thank you, Dr. Austin, for your outstanding presentation. So this wraps up the presentation part. But before moving on to our Q&A segment, I'd just like to express our gratitude to our speaker panel for their outstanding presentation and for sharing part of their evening with the resident and student members for attending tonight's webinar. So if you folks have any questions, you can go ahead and put them in the chat. We can wait a couple moments to see if there's any questions. Okay, so this question is for baseball. Do you mind talking about the internal brace procedure and how common it is and when to use it?
So, the UCL repair or the UCL internal brace is UCL repair procedure. The most common surgical procedure is UCL reconstruction, where you take a palmaris longus graft in a lot of situations and make a new UCL. Now, a newer procedure is UCL repair, where actually you repair the two ends of the torn UCL together and you place a brace around it. So an internal brace, kind of like a bio brace. There are certain indications for it based on certain, where the tears occur. That's more of a surgical answer, and a UCL surgeon would be more appropriate to tell you the specific indications for it. But the pro of a UCL repair with internal brace is a faster return to play. So we may be looking, where it's usually 12 to 15 months for a UCL reconstruction. An internal brace procedure is more 8 to 10 months. And so that's really the pro of having the repair. But we don't have as much data as far as how long they last in the long term versus reconstruction. And then also as far as indications, that'd probably be a better, surgical question than for me on the non-surgical side.
Thank you. And then as a follow-up to that, someone else is wondering, after players sustain UCL injuries, what are some key markers you assess to determine they're ready for full activity?
Yeah, so I think a lot of direct talk with the physical therapist as far as when they are ready in their physical therapy program to begin a throwing program. So, is their kinetic chain strong? Do they have good scapular mechanics? Does it look like their mechanics overall and their strength is put together, and they're set up to where they're not going to have a breakdown if they begin a throwing program. So, that throwing program, you can start as soon as 6 weeks. That's the absolute soonest. I don't love doing that. Sometimes we give guys 3 months after a PRP injection. So it's a lot about talking to the physical therapist, and then also following their ultrasound. So they come back in the clinic. If you still notice that they have some gapping and UCL insufficiency, they may not be ready yet. And so, we will track their gapping on their ultrasound and make sure that returns back to normal before allowing them to progress.
Thank you.
Perfect. Thank you so much. And then for Dr. Austin, there is a question. Do you know why knee injuries are more common in professional athletes?
That's a good question. So I would argue, I would say a couple of reasons. So first, I would say just the sheer volume. So it goes back to kind of the principles I talked about as far as the setup for both acute and overuse injuries. So professional athletes tend to have a much longer schedule. And then you have to think about the mechanics of sport. So for something like basketball, your knee is really is getting the most torque. It's getting the most it's absorbing the most sort of forces when you're stopping and starting, when you're pushing off the jump and things like that. So it's kind of like that lever point, and it does make it the most vulnerable, and especially in women athletes as well, with the type of sport like basketball where it has so many dynamic movements. Historically, women have been more quad dominant, meaning the front side of their legs are much stronger than the back side of their legs, which does put them at risk for having ACL or knee injuries, which a lot of those injuries are non-contact injuries, as I mentioned. So I think it's just the nature of the sport. I think it's the volume of the running and jumping that's happening and the sort of surfaces that are being used. And then the twisting and turning mechanisms along with the jumping mechanisms, I believe, would put people at more risk. But ultimately, as you saw in one of the slides that I did, ankle injuries aren't far behind. So if you think about the two lever points where you're pushing and jumping and moving, your ankles and your knee are going to be the more common injuries.
Perfect. Thank you so much. So I don't think there's any other questions. So we're going to go ahead and wrap it up for tonight. But I do want to encourage everyone to join the MSIG webinar next week, Thursday, January 16th at 8:30 p.m. Eastern. The series will continue on textbook injuries, and there'll be 4 presentations. Dr. Joanne Allen will make presentations on sailing. Dr. Christine Carlson will talk about rowing. Dr. Kelly Ryan will talk about equestrian, and finally, Dr. James Eggert will talk about rodeo. So it's been my pleasure serving as the moderator for tonight's webinar, and thank you everyone for coming.